Um, I wanted to talk with you about DBT for substance use disorders. And I'm having a thought that substance use is something that comes up with DBT clients, independent of whether they're in a program that's specific to substance use disorders or not. And that in some ways, self-harm itself can be seen as something of an addictive behavior, where the person often wants to stop and finds themselves continuing despite repeated efforts to avoid it. So, I wanted to talk a little bit about the similarities and differences between programs, DBT programs that are specifically focused on substance use disorders and DBT programs that are standard DBT. So what are the main similarities and differences between standard DBT and DBT SUD, or DBT for substance use disorders? Well, a big one is targeting. So targeting in standard DBT is life-threatening behaviour first in individual sessions, followed by therapy interfering behaviour, followed by quality of life interfering behaviour, followed by increasing skills use. And for DBT for substance use disorders, the hierarchy is the exact same, with the assumption that substance use is the highest, like the top quality of life interfering behaviour. And of course, there are a myriad of ways in which substance use may interfere with therapy as well. So, for example, people might arrive to sessions under the influence. They might not attend because they're high and don't feel like coming. They may neglect to take replacement medication that is important to them for maintaining abstinence from substances. But the main kind of assumption is that if you're working with someone who's struggling with substance use, that's going to be the top target in terms of the myriad of behaviours that are interfering with their life. So that's number one. Number two is there are 7 skills that are specific to substance use disorders. So they're called the skills for when the crisis is addiction. And they are located, the handouts and worksheets for those are located in the back end, of the distress tolerance module. And if you look at the curriculums, in the chapter that's dedicated towards describing various curricula for teaching skills, the skills curriculum that's specific for a DBT SED program recommends having the majority of the skills, the substance use disorder skills, taught after distress tolerance or in the distress tolerance module, with the exception of the skills that are referred to as clear mind, clean mind, and addict mind, which are typically taught in the context of when teaching mindfulness, teaching the mindfulness module. And I realized that the terms addict mind and clean mind are of their time. So this manual was developed in 2014, well, was published in 2014 and was developed in the years preceding that. And that there are multiple people that may find those terms judgmental and ill-fitting for DBT. And there was a publication in an article in the DBT Bulletin written about this exact issue, where Hedeman essentially presents the case for having flexibility about using these labels. So clean mind has also been referred to as naive mind, for example. And addict mind has been referred to as use mind or addiction mind. So don't feel like you've got to be a slave to these labels. You can change them to fit your own purposes and your own worldview about this stuff and what's effective with your communities. So the 7 substance use disorder skills, I'm not going to go into them in detail because there are whole chapters referred to them, like describing them. However, they comprise, basically you can remember them by the acronym DCBA. And the idea of this is you're backing away from substance use. And the first couple of skills are active mind, clean mind, and clear mind, and dialectical abstinence. So dialectical abstinence is this idea of marrying the goals of DBT, which are essentially about abstaining from the drug, the substance or substances that are causing you the most problems in your life, while also radically accepting that you are not infallible, that you're not bulletproof, and that lapses are likely to occur. And so it's trying to take the best of both worlds, like the best of harm reduction and abstinence, and sort of have your cake and eat it too. So the benefits of abstinence are that usually people have a longer amount of time actually abstaining from a substance. The downside of the abstinence model is that when people fall off the wagon, they fall hard, and it takes them a long time, or often longer, to get back on the wagon. So balancing that out from harm reduction, where the focus is on trying to prevent relapses and also just trying to limit the harms that substance use can result in. The benefits of that are that you tend to get back to abstinence faster, and you don't. And the downsides are that you are more frequent in your lapses, that you more frequently fall into relapsing or using substances. So the idea of dialectical abstinence is essentially to be single-mindedly, mindfully focused on abstinence, and that it's not an option to use, that falling, like stopping abstaining, is not possible, is not an option. And that if you lapse, then the idea is to get back into abstinence as quickly as possible. So it's sort of like an Olympic athlete, like just aiming for gold, like winning every race, every time, and not sort of allowing the possibility of defeat to enter your mind as the starting gun is about to go off. And if you don't win that race, if you sustain an injury, working to recover and to get back in the race as quickly as possible, like to get back into competing as quickly as possible. So the other skills, I'll just list them out here. Okay, dialectical abstinence, clear mind, addict mind, community reinforcement, adaptive denial, alternate rebellion, building bridges, burning new ones. That might be 7 skills. And with the exception of clean mind, clear mind, and wise mind, all the rest are taught in distress tolerance, with the exception of community reinforcement, which is about obtaining reinforcement from your community and also reinforcing yourself. So it's very much an interpersonal skill. So it's put in the interpersonal section. So that's how the skills differ. And then 2 other big things about substance use disorders, like DBT for substance use disorders, is that there's a much greater focus on staying attached, because in general, the research has indicated that using the DBT idea of butterfly patients and attached patients, where attached patients show up every session, tend to get upset when their therapist goes on vacation or can't meet them one week, but show up every time, whether they're happy or irritated, and the MO is to be engaged and attached to their therapist. In contrast, Butterfly patients are ones that sort of flutter in and flutter out, might miss quite a few sessions in a row, and then show up in crisis, where the relationship with the therapist is perhaps not as important as other relationships in their life, like, say, a relationship with a partner or their relationship with a substance. And so attached patients normally show up. Attendance isn't the issue. It's figuring out the interpersonal ruptures that can often happen within session. Butterfly patients tend to not show up and not be in touch as much, use phone coaching less frequently, and just seem less engrossed in therapy. And therefore, a lot of strategies in DBT for substance use disorders are about increasing and amplifying that attachment. So right at the beginning of working together, the therapist will be asking the person, if you become lost to therapy, how can we find you? Who do we need to speak to? Who else do we need to involve in this therapy? Who's important in your life? What are the places we should go looking for you? Can I get permission to go looking in those places, speaking to those people, if I'm not hearing from you and you've missed several sessions in a row and either your phone's not working anymore or you're just not responding to me? What's going to work here? So we speak explicitly about the butterfly problem and then figure out together how to solve it. And so as a therapist, you might be in touch a lot more frequently with your client who's in DBT SUD, just to check in and to maintain this warm engagement, rather than every phone call being about phone coaching. All right, that's a little taster of what DBT for substance use disorders involves. I hope you find it useful.